Good evening to everyone and welcome to today's session. Today we shall review 4 important topics: penicillin and ACE inhibitors and autonomic nervous system pharmacology. Already we have discussed beta blockers, adrenoceptor blockers, alpha and beta blockers. But we need to review cholinomimetic, anticholinergic, and the general structure of the autonomic nervous system pharmacology. So we welcome our online students. Echo is there. Can you decrease that sound? Okay. Yes, I think echo is better now. Slightly decrease that. Okay. We welcome Dr. Harika, Anuja, Vikas, Brahmaramba, Ritu, Jivita, Chandan, and the students in Tirupati, Vizag, Kurnool, Kakinada. Welcome. Yeah, that's good. Clear. Sir Alexander Fleming days, there was no MD entrance exam. There is a better time to do research. But after that, the Goodman-Gilman's pharmacology textbook has become so fat. Honestly, how many have you not heard of Goodman-Gilman textbook of pharmacology? No? Ajay didn't listen about it. Thanks for the honest answer. You need not know also, unless you are doing masters in pharmacology. Good. Is it clear? Is the voice clear? Yes. Now, penicillins from then till now are the gold standard drugs. They are the analogues of the alanine dipeptide. They contain a thiazolidine ring with a beta-lactam structure. And all that antibacterial activity is because of that beta-lactam, which is the important component of penicillin. And any modification to the aliphatic side chain, which is attached to the beta-lactam ring, is the one which is responsible for the difference in the pharmacological properties between one type and other type of penicillin. Even for the drug resistance against penicillin also, the secret is in that aliphatic group which is attached to this beta-lactam ring is the point of interest. So how will basically the penicillin will be acting is an important question. It is the bacterial transpeptidase which is being inactivated by the penicillin. What is the purpose of this transpeptidase? Transpeptidase. So that's the reason it will be linking one amino acid to the other. So the cross-linking of the peptidoglycan polymers in the bacterial cell wall by this transpeptidase is responsible for the integrity of the cell wall of the bacteria. That is basically inhibited by the penicillins, and that leads to the loss of rigidity, and bacteria become susceptible to the rupture. For the penicillin to act basically to inhibit this transpeptidase, first it needs to bind to penicillin binding proteins and inactivate them. These penicillin binding proteins are also involved in cell wall synthesis, and their binding is responsible for the inability of the bacteria to synthesize the cell wall. And what is penicillin? Is it bactericidal or bacteriostatic? Is one of the favorite question of the examiner. Any cell wall synthesis inhibiting drug will end up to be a bactericidal drug. The one which basically goes and affects the nucleus and the replication becomes a static drug is the fundamental premise. So that is the reason for the between gram negative, gram positive if you take, which is susceptible to penicillin, First it need to have a good cell wall synthesis must be important, then only it is susceptible to the penicillin's action. So which group of organisms in the microbiological fauna and flora are susceptible, doctor? Gram-positive bacteria which have a thick wall are the ones which are most susceptible to the penicillin, is what you have to fundamentally remember. So penicillin G is sensitive to penicillinase. The organism can become very intelligent and can be able to destroy the penicillin. Penicillinase or beta-lactamase, and the beta-lactamase producing bacteria will inactivate the penicillin G by opening up the beta-lactam ring of the penicillin. If the organism knows how to break down that beta-lactam ring, then penicillin can no more act as an agent which will inhibit the transpeptidase, is what need to be remembered. So what are all the drugs that you know which are known to be inhibitors of the cell wall synthesis, doctor? Penicillins, cephalosporin, cycloserine, vancomycin and bezitracin, they are all the group of drugs. Vancomycin and bezitracin are all the group of drugs which are known as the cell wall synthesis inhibitors. So what is the main reason for the penicillin resistance? It is that penicillinases, which are beta-lactamases, which are produced by the organisms, bacteria, is mainly responsible. So how will one bacteria tell its son and grandson the intelligence to be not killed by the penicillins? Basically, the genes of the beta-lactamases can be transmitted at the time of conjugation, and also small plasmids through the transduction can be able to carry this penicillinase producing intelligence from one organism to the other, is what need to be remembered. So what are the penicillinase producing organisms which are penicillin resistant in the microbiology? Staph aureus, E. coli, Pseudomonas, Neisseria, and the Proteus and Bacteroides. They all came to know that Alexander Fleming is no more alive and how to kill the penicillin, and they are the classical penicillinase producing organisms. Sometimes the organisms may lead to the development of the progeny which doesn't have receptor for the penicillin binding protein. Even that can lead to development of penicillin resistance. Sometimes they can create an impermeability for the entry of the penicillin, and if a bacteria lacks cell wall, for example mycoplasma, it is not vulnerable to the action of the penicillins. Similarly, if it is not metabolically active organism like a spore, it is also not penicillin susceptible, is the point that you need to appreciate. Penicillins are generally absorbed rapidly after you give it enterically, and the enteric absorption is much more erratic compared to parenteral administration. They go to all the fluids. For that matter, if you want to treat the syphilis, one of the wonderful drugs used to be penicillins because of their wonderful CSF and ocular fluid penetration, is what need to be remembered. You know amoxicillin? Earlier days we used to have pentits tablets. In the school days, if there used to be any small abscess, taking pentits used to be a every home OTC medication kind of a thing. But what is the difference between amoxicillin versus the other penicillins? Whenever you take a penicillin, acid will try to destroy it in the stomach. So acid resistant formulation of the penicillin is basically your amoxicillin, is what need to be fundamentally appreciated. So let us look at some of the common penicillins and their uses. We have penicillin G. Penicillin will be angry if you don't call it with respect. Sir G, Murli G, penicillin G. So penicillin G and penicillin V, what is the difference? We'll come to that point. So gram-positive organisms which are aerobic like pneumococci, streptococci, but not Streptococcus faecalis. We don't use penicillin G and V for faecalis. And non-penicillinase producing staphylococci. Generally staphylococci don't listen to the word. Most of the staphylococci already know how to kill penicillin, how to kill methicillin, how to kill its grandfather vancomycin also. Resistance is widely prevalent. So that's the reason penicillins are not that effective against the staphylococci. Then gram-positive aerobic rods like Bacillus and Clostridium perfringens, diphtheria, listeria, they're all highly vulnerable, is what need to be remembered. So you all know actinomyces and actinomycosis. Penicillin is the drug of choice. Very few infections it is the drug of choice. It is the drug of choice for all types of actinomycosis, is what you need to remember. Then gonococci, meningococci, which are gram-negative, are still vulnerable. Then gram-negative rods, none of them will listen to penicillin basically. Gram-negative rods don't listen, but gram-negative aerobic organisms, gonococci and meningococci, will listen to it. Then most of the anaerobes are susceptible but not Bacteroides. These are all important MCQs. Which organisms except examiner loves to ask. First in microbiology you need to know which organism belong to which class. That we will anyway master. After pharmacology we will pick up micro instead of going to pathology. Because pharma plus pathology looks like drinking a medicine syrup. So better have a variation. Except Bacteroides. And for the oral anaerobes, penicillin is effective. Then in neurosyphilis, if I ask you what is the drug of choice, it is the aqueous or crystalline penicillin G is the one, and procaine penicillin also can be given. So basically what is penicillin G procaine and penicillin G benzathine? Lot of people miss what is the main difference. Benzathine penicillin and procaine penicillin, anything is penicillin G. Basically they both are the suspensions of the penicillin, and why do you want to mix it with procaine and benzathine? They basically prolong their half-life so that the number of injections that you need to give will be lesser, and procaine being an anesthetic, it is relatively painless. So procaine and benzathine, purpose of adding up with penicillin is to prolong its half-life, is what you need to remember. So is the voice, first for you it is audible? Right. I hope that for the online students the voice is clear enough. Please punch. Is the voice is clear enough? Clear and loud? Yeah. Now probenecid, what is the purpose of this? Clear. Very good. Probenecid is a uricosuric drug. Earlier days we used to use lot of probenecid, but slowly with the advent of other better drugs we slowly brought down the usage. It blocks the renal secretion of penicillin. We don't want penicillin, a poor fellow who purchased it, losing it in urine. So prevent it from being lost into urine so that therapeutic levels will increase. That's the purpose of adding the probenecid, which is rarely used nowadays. So by adding probenecid, secretion of the penicillin is prevented so that the penicillin duration of action will basically increase, is what need to be remembered. So if you look at the penicillin G, it has a very rapid renal excretion. Nearly about 90% of it is tubular secreted, is what you have to basically appreciate. The penicillin G is a acid labile substance. That's the reason it is easily destroyed by the gastric juice, gastric acid. So that is the reason either intramuscular or intravenously we give rather than putting into the mouth of the patient. Then procaine benzoyl penicillin we said, no? Benzathine penicillin G and procaine penicillin G. So procaine penicillin is nothing but local anesthetic agent procaine added on to the benzoyl penicillin. You can give it a deep intramuscular injection, it becomes slowly absorbed into circulation and ultimately hydrolyzed into benzoyl penicillin, and that will provide a prolonged low concentrations of the penicillin, benzoyl penicillin. Procaine, due to its anesthetic properties, the intramuscular injection is relatively less painful if you give procaine penicillin, is what you need to appreciate. So what are the specific indications where you want to use the benzathine penicillin, doctor? Rheumatic fever prophylaxis. In a country like India, finding mitral stenosis as a consequence of rheumatic fever in Lachava, Buchaka, Rajava, everybody, our poor farmers and their wives and mistresses and their lives are being complicated, not by the modernity but by simple rheumatic fever, which is easily treatable. If you know that penicillin, patient should be convinced to regularly take penicillin. Early or latent syphilis is another important scenario where benzathine penicillin is used. Now, is there any acid resistant form of the penicillin? We have penicillin V, which is called phenoxymethyl penicillin. The difference between penicillin G and V is only V is more acid stable, is what you have to basically appreciate. Now comes the most crucial part for the MD exam. What is the classification of penicillins? Penicillinase resistant penicillins. Who falls into this group? Oxacillin, dicloxacillin and nafcillin, they all fall into this. So we said a lot of staphylococci are all penicillin resistant. They can be treated by giving oxacillin, dicloxacillin and nafcillin. But later on, there is lot of methicillin resistant Staphylococcus aureus which became prevalent. So that even this penicillinase resistant penicillins became unpredictable. Then few penicillins are called extended spectrum penicillins. Ampicillin, amoxicillin, ampicillin plus sulbactam or amoxicillin plus clavulanic acid. These are all called extended spectrum. Does extended spectrum mean to say that they are resistant to beta-lactamases? No sir, that is a common confusion. Beta-lactamase resistant organisms, if you say that is penicillinase resistant penicillins, means only 3 of them: oxacillin, nafcillin, dicloxacillin. But extended spectrum penicillins, if you use, if the organism is beta-lactamase producing, then they very much become inactivated, is what need to be remembered. Then why they are called extended spectrum? Generally penicillin is only effective for the thick-walled gram-positive organisms, no? But if you use an extended spectrum penicillin, the gram-negative coverage will increase, hence called as the extended spectrum. But resistance against this extended spectrum also has become quite rampant. So what is ampicillin effective against? Lot of organisms, don't remember it. Amoxicillin is effective against. Already ampicillin, if it is a wastage, then why to remember amoxicillin? You remember extra gram-negative coverage, that's all you can remember. But amoxicillin should be remembered because there is a better oral absorption. For endocarditis prophylaxis, if you want to use before any major procedure, if you want to use the penicillin, then amoxicillin can very much be helpful. Then piperacillin, Pseudomonas and Enterobacter. These two are highly vulnerable. Piperacillin is the one which is being basically used. Then what is clavulanic acid? It is similar to that of the penicillin structurally, but it has no antimicrobial activity by itself. If you add it, then it will inhibit that beta-lactamase, because amoxicillin by itself, in spite of being an extended spectrum of penicillin, is vulnerable to the beta-lactamase inactivation. So clavulanate prevents that inactivation. Hence we combine amoxicillin with clavulanic acid. So penicillinase producing organisms become vulnerable if you combine amoxicillin with clavulanate. So we use, can you slightly increase that? If some echo comes, please let me know. If echo comes, please punch and let me know. Slightly decrease, slightly. Amoxicillin plus clavulanic acid. We use the combination for oral administration. Penicillin and clavulanic acid. We give that for intravenous and parenteral administration. That's the reason we use these combinations with clavulanic acid. Then what is sulbactam and tazobactam? The other important extended spectrum penicillins. Basically, they are also beta-lactamase inhibitors, just like clavulanate, which are related to the penicillin. So you can combine ampicillin with sulbactam, then tazobactam can also be combined, and ampicillin plus sulbactam, if you give, it provides a coverage which is very similar to combining amoxicillin plus clavulanate. Then what is the common combination of these drugs that we basically give? We said sulbactam plus ampicillin is a common combi. Similarly, piperacillin plus tazobactam is another very common combination. What is the role of tazobactam or sulbactam? Same role which clavulanic acid is having in protecting the penicillin and making penicillinase resistant organisms still become treatable. Then this ampicillin sulbactam, if you take, we commonly use it to treat the gram-negative organisms and anaerobes. Then piperacillin tazobactam, very commonly used combination in the intensive care unit antibiotic. You will go like a warrior to the intensive care unit, no? You will have Agneastra, Vayuvyastra, like different astras, all the antibiotics. Until patient dies, you will be using this, that, this, and ultimately, if everything is resistant, you are helpless, right? So, what are the adverse effects of the penicillins? They can lead to hypersensitivity, rash, anaphylaxis. How frequent hypersensitivity is seen? 10% of your patients. Be sure, 100 people, if you write prescription, 10 of them can go to consumer court and file a plea that rash is because of you. Within 2 minutes, anaphylaxis can occur, or it can take 3 days. After giving, keep praying God for 72 hours, nothing should happen to the patient. Then there is a direct irritation or pain on injection. Why I am saying this is, we had one professor of surgery, very eminent surgeon. Simple penicillin reaction patient got. He sued him, and his lifetime earnings he has to end up in giving the patient to come out of the soup. Simple penicillin. So until his retirement day, every time in ward rounds, whenever he used to discuss a case, first he used to start with his agonizing story with the penicillin reaction and being sued by the patient. So sometimes luck may not favor. Now, endocarditis prophylaxis. This is one area which anyway we will discuss in general medicine, but a short note. So whom do you want to give? Those who have prosthetic heart valves, who are already diagnosed with endocarditis previously. Those who have a cyanotic, not acyanotic, PDAS, DVSD I am not talking about. I am talking about cyanotic heart disease, stop, etc. Then patients who have a surgically constructed systemic pulmonary shunts, like Beta-lactamase shunt, etc., etc. Then who are the patients who are at intermediate risk of endocarditis, doctor? Other than cyanotic heart disease with other congenital abnormalities born, like AS, DVSD, PDA, they all come under intermediate risk. Those who have acquired valvular dysfunction like a rheumatic fever patient, and those who are having hypertrophic cardiomyopathy also belong to this group. Then for what procedures is endocarditis prophylaxis is premier, doctor? Dental procedures, invasive respiratory tract invasion, bronchoscopy, tonsillectomy, then GI and genitourinary tract manipulations like endoscopy, colonoscopy, cystoscopy. You will be releasing organisms into the blood which will go to the heart. So we need to give prophylaxis. So the most commonly used agents for the endocarditis prophylaxis, if I ask you, amoxicillin and ampicillin. Another common favorite MCQ of examiner. If the patient is allergic to penicillins, then clindamycin and azithromycin are considered to be the best drugs. So before we say goodbye to this topic of penicillins, this is one area which you need to be very sure, doctor. What is the classification? We have the penicillin G, penicillin B. Gram-positive cocci are highly vulnerable. Gram-positive rods may bacillus is vulnerable. Then gram-negative cocci may gonococci, meningococci are vulnerable. No gram-negative rod will listen to it. And most of the anaerobes except the Bacteroides, which generally complicate the wound infections. Then penicillinase resistance are same thing. Before we say goodbye, let us touch base what we learned. Nephicillin, oxacillin, dicloxacillin, and you can give it for staphylococci. Then extended spectrum में ampicillin, amoxicillin, sulbactam, clavulanic acid combinations. Most penicillinase producing staphylococci you can use, and they have an extra gram-negative coverage. Again, it what? Salmonella, Ketch influenza, Proteus, Enterococci, these gram-negative are there? No, they are not treatable with penicillin G and B, but they can be treated by this extended spectrum penicillins. Then we have anti-pseudomonal penicillins, ticagrelin, clavulanate, or piperacillin can very much be used against the pseudomonas. So that's all the story that you need to be 100% sure.